So, good morning, all. Warm greetings from Amrita Institute of Medical Science, Kochi. My topic today is insulin antibodies, and I must confess that being a surgeon, probably I'm not the ideal person to talk about this, but I will try my best to give some insight regarding the same. So we all know pancreas consists of exocrine cells, 98%, and 2% of endocrine cells, of which mainly 60 to 70% are insulin-producing beta cells, roughly around 20 to 25% are alpha cells, 5 to 10% delta cells, and then gamma and epsilon cells. So in between the acinar cell lies the endocrine uh, cells, islets of Langerhans. Now, now it's almost a definite proof that type 1 diabetes mellitus occurs as a result of immune mediated destruction of islet cells of Langerhans. So what are the evidence? There is mainly lymphocytic and sometimes plasmacytic infiltration of the islet cells in the early part of the disease, particularly the cells containing beta cells. And there is a susceptibility of developing this disease in certain HLA alleles like HLA-D and DR. um, Around 93 to 98% of patients are bearing this HLA D and DR alleles, and there is a high prevalence of islet cell autoantibodies at the onset and early part of the disease. So these can be basically divided into islet cell cytoplasmic antibodies detected way back in 1974, and islet cell surface antibody detected in 1978, of which the important antibodies are islet cell cytoplasmic antibodies. So the antibodies are against the cytoplasmic organelle, mainly the insulin granules. So both insulin as well as proinsulin. So it usually appears in 50 percentage of new onset diabetes mellitus, especially in young patients less than 5 years old. The next one is the glutamic acid decarboxylase 65 antibody, the GAD antibody, which is seen in much more higher proportion, 70 to 80 percentage, especially in patients with HLA-D and DR allele group. So usually these patients are less than 10 years, and once a GAD is positive, there is an association of other polyendocrinopathies like Addison disease, Hashimoto's thyroiditis, vitiligo, pernicious anemia, etc. The third one is the antibody against the zinc transport membrane protein, and the last one is the IA2 antibody. So together, these are called diabetic antibodies, diabetic autoantibodies. Now here is the beta cells, and here you can see the insulin secreting granules, and this is IA2 surface, the secretory granule membrane antigen, zinc transport, um, transporter membrane antigen, and within the granule, insulin antibodies can form against the insulin granules. So the antibody against insulin, it's not very specific to type 1 because it can happen as a result of administration to exogenous insulin. And if you look at the antibody, roughly around 90% of the patients, one form of antibody among these will be present during their and their pathogenic process, especially in the early part of the disease. And 10 percentage you probably won't find any antibody. Now, coming to the pathogenesis of type 1 diabetes mellitus, we all know it's an immune mediated destruction, especially in patients who are genetically predisposed to this disease. It is basically divided into stage 1, stage 2, and stage 3. Stage 1 and stage 2 are preclinical or pre symptomatic stage, and stage 3 is the full blown diabetic stage. So, if you look at here, stage 1 disease, if you do fasting glucose, I mean, the glucose tolerance test, the fasting glucose will be less than 110, and 2 hour postprandial sugar will be less than 140. That means they are not diabetic, but in such patients, if antibodies are present, their 5 year risk of developing full blown diabetes is around 45 percentage. Now, in stage 2, the fasting glucose is slightly more, 110 to 124, and 2 hour ppbs is around 140 to 200. In such patients, if one or two more antibodies are present, their 5-year risk of developing full-blown diabetes is around 75%. And in stage 1, if the 10-year risk is around 70%. So this stage 1 and stage 2, this pre-symptomatic stage, if you can identify them early, probably we can do some sort of a immune therapy, and probably can arrest or prevent further progression of diabetes mellitus. Now, what are the clinical relevance? So, it's a marker of autoimmune type 1 diabetes mellitus. It predates and predicts type 1 children, and also we can diagnose type 1 diabetes mellitus. And there is a potential implementation of arrest of pathogenesis, that is immune prevention. If we identify this patient early, we can counsel the family and support the family. And in post pancreas and islet cell transplant patients, roughly around 5 to 10% of patients, the antibody may recur. So in such patients, it may predict early graft failure in such patients. So probably you need to modulate your immune therapy. Now, it's also useful in monitoring immunotherapy trials. Now, few words about antibodies to exogenous insulin. So this is a troublesome situation. It can result in very difficult glycemic stability. So basically, these are two types. One is the low affinity, high capacity antibody. So here the antibody binds loosely, and after some time it releases it unpredictably, which will result in sudden hypoglycemia. So these patients, they develop brittle diabetes and sometimes late postprandial hypoglycemia. The second one is high affinity and low capacity antibody. It binds with the insulin firmly and neutralizes the insulin, which will result in insulin resistance. Now, when to suspect? When there is extreme fluctuations in the blood glucose despite maximum care, or unexplained insulin resistance, that more than 2 unit per kg per day, or recurrent hypoglycemia, or when you check the total serum insulin, there will be disproportionate levels of insulin compared to the administered dose. So when these situations appear, one should suspect antibodies against exogenous insulin. How to diagnose? You are supposed to measure the serum insulin antibodies, either radioimmunoassay or ELISA. So IgG is more important. Also, you can measure the free versus total insulin. So the antibody bound fraction artificially elevates the total insulin level. Now, how to manage this patient? It's mainly supportive in the initial part, frequent glucose monitoring, adjust the insulin doses dynamically as per the need of the patient, avoid large boluses and prefer small basal boluses, and change insulin formulation, change the formulation to human derived insulin, or one can use insulin analogs. These are less immunogenic, like lisipro or glulisine or ditamir. And also one can minimize the antigenic exposure by using continuous subcutaneous insulin infusion, or one can use insulin pump. So in type 2 diabetics, one can temporarily discontinue insulin if feasible, and move on to sulfonylureas. Now, in severe cases, there may not be any other choices available in such patients. Probably one has to stick to immunosuppressive therapy. Usually, initially started agent is prednisolone, 0.5 milligram to 1 mg per kg, and which will be tapered over a few weeks. Other options are immunomodulators like azathioprine or mycophenolate, and in severe cases, maybe rituximab. And rarely plasmapheresis is also may be indicated, especially in patients who develop troublesome dermatitis. Now, uh, so to conclude, the take-home message is that 90% of patients at some point of their disease process, diabetic autoantibodies will be present. So it has got an emerging role in predicting disease onset, prevention, and progression of the disease. However, their relevance in routine clinical practice is not yet to be fully defined. A lot of researches are ongoing. Probably there may be a role in future precision medicine. Thank you so much.